Good morning and welcome to the Yakima County Board of Health meeting of May the 29th, 2024. We will start with roll call, please, or introduction. Thank you.
Okay, we do have one member of the public.
Hi, Jennifer Maxwell. Met you before, family physician. Nice to meet you.
Thank you.
Okay, all right, thank you. And we're going to acknowledge that Commissioner McKinney is online this morning. Good morning.
Good morning.
Next, we'll move to the consent agenda. This consent agenda will be passed by one motion. All items listed below are considered to be will be executed by one motion. No separate discussion of the items unless a board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence of the agenda. Does anyone wish to have an item removed from the consent agenda? If not, Mr. Harbach, would you read the agenda?
April 24, 2024, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in April 2024 in the amount of $894,259.13.
Thank you. I'll entertain a motion to approve.
Motion approved. Second.
Motion and a second to approve the consent agenda as read. All in favor, please say aye. Aye. Any opposed? The motion passes. Thank you. All right, now we'll move down to item 5, which is the spotlight. And this is the FBI response in Yakima County by Melissa.
Thank you. Good morning, everyone. I'm a little under the weather, so just bear with me. Hopefully I'll get through this without any incidences. But so this month's spotlight is on the SGI response in Yakima County. It's going to focus more specifically on syphilis in Yakima County. Next slide, please. So just an overview of what syphilis is. It's a sexually transmitted infection caused by the bacterium Treponema pallidum. It's classified or divided into 4 stages depending on clinical findings. So when someone presents, usually within the first 2 to 6 weeks of what we call primary syphilis, they're going to have classic symptoms such as a chancre or a painless ulcer at the infected site. If they are left untreated, it will progress to secondary syphilis, which can include a skin rash on the palms of your hands and sometimes also on your feet. And that will usually be within the first month to 6 months after infection. If still left untreated, it will progress to latent syphilis, which is a period where there's no visible signs or symptoms on the individual. And then if they continue to be untreated, it can progress to tertiary syphilis, which means you can develop symptoms 10 or 30 years down the road having not been treated. And it can infect different organs, including your heart, your brain, and then sometimes you can also develop what we call neurosyphilis, where it affects your eyes, sometimes your ears. And then, of course, there's congenital syphilis, which occurs when a mother passes syphilis on, if untreated, to her infant during pregnancy and then on to delivery. Next slide. So the good news about syphilis is there is treatment. This is one of the STIs that there actually is treatment for. It's treated with penicillin. So ever since penicillin came out, syphilis has been around for hundreds of years, but penicillin is a great treatment for it. So with the invention of syphilis, we've been able to, or penicillin, we've been able to treat syphilis well. And the dosage depends on what stage. So those 4 stages I spoke about, depending on what stage they're in, primary, secondary, latent, or tertiary, depends on what their treatment regimen is going to be. And then also the purpose of reporting is obviously for surveillance, to be able to report those cases, and then also identifying cases, getting them treated, identifying their close contacts, their sexual close contacts, getting them treated as well, and reducing further spread within the community. Next slide, please. So now we're going to talk a little bit about the syphilis case rates. Next slide. I wanted to just kind of show a graph of what syphilis has looked like historically up over the last 20 years. So in the 1950s, syphilis was way down. That was the last time we really had much going on in syphilis. And then especially as the HIV was happening in the 80s and 90s, people became very aware of their sexual practices, practice safer sex. And so we saw syphilis decrease. And then as HIV became more of a chronic condition, things kind of loosened up. We started to see an increase in our syphilis cases. So you can see where we're trending upward. And this is national data showing the trend over the last 20 years. Next slide. And then now we're going to focus a little bit more onto the last CDC's data and state's data. It's always a little delayed, so it's not going to be up-to-date data just because it's all preliminary. But you can see how the case rate, the 39.6 in 2019 was our case rate for national in 2019, and then 62 in 2022. So you can see that increase. Next slide. For our state, we went from a case rate of 11 to 24 from 2019 to 2022. And next slide. And then looking at Yakima County, we went from a case rate of 16.1 in 2019 to 137, which is well beyond what the national average is. So we have, we identified that, you know, starting in 2021, we saw a huge increase in our syphilis cases in Yakima County. Next slide. And then just before I move on to a little bit more into our STI response, I just wanted to kind of show that we're going to talk more specifically about syphilis, but gonorrhea and chlamydia are still predominantly our highest STI cases in Yakima County. So just wanted to show those cases and rates for gonorrhea and chlamydia. So in 2022, when we were in the middle of our syphilis outbreak, the State Department of Health reached out and offered to assist us in our STI response by providing funding for an STI nurse to focus their efforts in our in STI specifically. So I presented them with a budget, and we were able to get an FTE equivalent for an STI nurse. And this allowed us to increase our testing from 1 to 2 days per week here at YHD. We also expanded our treatment to 5 days a week, whereas before we were only able to test and treat on Wednesdays. Now we can offer treatment 5 days a week here, which is free to the public, and that's for individuals that we test, but also individuals that maybe a provider can't get a hold of, or lack of services, whatever it may be. They can always come here and get tested as long as we have a positive result for them. And then we also added our testing, of course, at our harm reduction sites. And we've also been able to implement field treatment options, such as if an individual is positive that's in one of the municipal jails that does not have a medical unit on site, they're not able to treat those individuals. Our STI nurse can go into those jails, treat those individuals, or if there's other cases where an individual cannot come into the office for whatever reason to be treated, we're able to go out there and treat them, like specifically like in our harm reduction sites. Next slide. And this is just going to take a look at over the last few years at the trend and what has happened with syphilis, switching from previously most predominantly in the MSM, or men who have sex with men population. It is now switched more over to a heterosexual population. So we're seeing more cases in our non-MSM population than historically. Next slide. So with that comes more heterosexual cases, which means an increase in women having syphilis, which then obviously leads to a trend or an increase in our congenital syphilis cases. And so that's what we've seen. This shows an increase in our rate of congenital syphilis as well as cases within Washington State. Next slide. And then the other trend that we've also seen within this particular outbreak, not just in Yakima County, but nationwide, but also that in Seeking County, it's still predominantly within the male MSM population, whereas Yakima County and nationwide, it has switched to an unhoused and drug-using population, which is why one of the important reasons why we're out there, our harm reduction site, doing testing and treating at our site in Toppenish. We identified 9 positive syphilis cases in 1 day of testing out there. Next slide. So this just kind of goes into our expansion as well with the funding we received. Testing at our harm reduction sites, we've added our hepatitis C, which is HCV, HIV, and syphilis rapid testing on Thursdays at our Yakima location. In Toppenish, we have hepatitis C, HIV, syphilis testing, and we've also been able to add in chlamydia and gonorrhea through our partnership with the tribe. They have a mobile medical unit out there with a functioning bathroom that allows us to do gonorrhea and chlamydia testing. And we're the first harm reduction in the state of Washington to be able to offer all of those STI services. So we're happy to have that partnership to be able to do that. Next slide. And this is just looking at how we've taken the burden off of the providers within the community by offering expanding our STI services. So for individuals who just need STI testing or treatment, they may not need any other services at the time. We're taking that burden off of our emergency rooms, our urgent cares, primary care providers. You can see back in 2022, before we had our STI nurse, we had attested 149 individuals through YHD. Through December of 2023, we had tested 320 and we're projected to test almost 500 this year. Next slide. And then the last thing I wanted to talk about in our response to our syphilis outbreak is our working with the University of Washington survey project. This is a grant funded by the University of Washington with researchers and physicians. They've interviewed approximately 15 stakeholders of STI services, including physicians and consumers of STI services in Yakima County. They're going to take that data and analyze it over this next year and identify gaps in testing and treatment. And then at the end of the year, they'll provide us with recommendations on their findings. And that's all provided to us by the University of Washington and their researchers to hopefully identify where maybe there's barriers to care, treatment. For instance, in Sea County, they have something where you can receive PrEP in your home. PrEP is pre-exposure prophylaxis to HIV. You can receive that service in your home. So if you don't have transportation, that takes away that barrier. Next slide. And then just bringing this back to how it meets our strategic goals. STI reporting is a mandated service. It's a notifiable condition in the state of Washington. We've been able to develop a network of community partners, including the tribe, University of Washington. We also partner with Yakima Neighborhood Health Services for individuals that were not able to treat, say they fall outside of our standing orders. Maybe they have an allergy to penicillin. We would refer those people over to neighborhood health where they can, we call desensitize or have more equipment in case there were a reaction. And then increasing the effectiveness and efficiency by providing these services here at YHD. We're decreasing the amount of time that it takes an individual to get tested and treated for an STI, which decreases the spread of disease to our community. Next slide. Are there any questions?
Any questions or comments from us? All right, thank you very much. Next, we move to our agency reports. We're going to start with Executive Director Andre Fresco.
Morning. Thank you, Mayor Byers, and good morning to the public. I wanted to begin by saying that we are working on a number of things. You'll hear from Andy and a team regarding H5N1, and so we've got a number of responses. We've also, again, been able to invest in community partnerships in a way that is exciting as well. So you've heard that from Melissa, and you'll hear some more in our report. One thing I wanted to talk about in terms of community partnerships is something that we've been working for a while now. If you recall, during the winter, we had a really difficult cold snap, and there were some concerns around the safety of the public. And part of that came to a question on preparedness. And we started some discussions with our partners, specifically Tony Miller at the Office of Emergency Management, that Yakima County lacks a fully functional emergency operations center, or is what's referred to as an EOC. And so it was concerning for us, really recognizing that for a large county, a geographically large county, and an important county in the center of the state, we didn't have the functional support that we needed. So we were entering into some discussions with Tony and the Emergency Operations Center, and then partnered with Yakima County to begin a process on a design phase. We were able to, at the health district, divert some monies that we have through the Public Health Partnerships Program and pay for this design phase. So I'm really very pleased about the partnership. I'm grateful that that we were able to get the state to agree to spend that money. Certainly grateful to the county for assisting with the process of finding an architect and working on that design phase. And then, of course, grateful to the Emergency Operations Center, or rather the Office of Emergency Management, to be interested in funding this project. So the goal is, again, to fund a design phase, which will give us a blueprint for what is needed. And then the real excitement begins with trying to assist with finding the funding. The goal being that the funding can come from the state or federal government largely to fund an emergency operations center. This is really in line with something that we believe in. One is strengthening our community partnerships at the health district, certainly acting as a catalyst for these kinds of projects, but also assisting in difficult financial times to make certain that those burdens don't fall on the county or cities that are member organizations of the Office of Emergency Management. So this has been exciting for us, but also a recognition, frankly, that rural Eastern Washington hasn't been invested in the way it should be. So that's part of our goal. Again, this is not our project. We're not directing it, but we're very grateful to be part of it. So that will go through the next few months, and then there'll be a blueprint, and then again, there's the long, arduous journey of securing funding, which can take a while. But we're very pleased about that because, again, this is something that we're looking at forward thinking for the future in terms of having this. The term that's used is a warm EOC, which is frankly a strange term. But what it means is that you can flip the switch on something like this and be able to have people have a fully functional emergency operations center in the time of disaster, which we don't have. And that's really of concern because we have had repeated emergencies. We continue to see environmental health hazards, and we certainly are entering into, as an example, the wildfire smoke season, fires. We're in a high desert. It's of concern. So it's a good time to start this process, and we're again really to be part of it. So if you have any questions, please let me know. The other is that I owed Commissioner McKinney an answer. I know that at our last board meeting, Commissioner McKinney had discussed her interest and actually her concern about the fact that there wasn't enough electrical infrastructure for electrical powered vehicles. So I reached out to the Department of Commerce. They have some grants they call resiliency grants, and that's part of electrifying Washington State. And I think there's been a push to try to create that infrastructure in Eastern Washington. This is not an area where I'm an expert, but happy to start that process. And again, I think that these are, I don't know if these are grants that are easy to come by or if it's a grant process that we would go through as a county, but I'm happy to be involved in that. Certainly feel that the infrastructure needed for electric powered vehicles or hybrid vehicles is necessary because, again, if you're on the pass and you run electricity in your car, that's going to be disastrous. So that's something we've been working on. Again, it'll be a long-term process, but happy to answer your questions if you have.
Questions?
Madam Chair,
Go ahead, Commissioner.
thank you. I just want to thank you, Andre, for that. And I will say that this is something that I've raised at the emergency management level. And I just, I appreciate you looking into it. And certainly it's not necessarily public health's sole lane to be in, but it does speak to the problem, which is that we have a legislature that has required us all to convert to electric vehicles without the infrastructure to support, and that does put the public at significant risk when we have a mass disaster, a mass evacuation situation. And so I think it's important to note that the state does not have a plan for mass evacuations in the event of a natural disaster such as Cascadia, when in the next few years we will all be required to rely upon an inefficient and unreliable energy grid relying upon solar and wind, and of course with electric vehicles that cannot be charged in the dark of night in the winter. So it's unfortunate, but hopefully by raising this issue, we will see some disaster management planning that is reflective of the reality that the state is pushing us towards.
Yes, thank you. And Commissioner McKinney, you raised a good point. This isn't the normal work of public health, but one of the things about our work in public health is to prepare for disasters. And so often disaster preparedness is considered something that you do in reaction to the disaster. And really what we're focused on and have been for a number of years is the resiliency of your community to respond to a disaster. If your community is more prepared, then less people are at risk. And so that's really what we've been focused on. And to the state's credit, they've been investing in our goals of that. As an example, when When I first came here, we had a very small budget and a very small portion of staff time, staff person's time working on emergency preparedness. We were able to strengthen that working relationship, and they invested in us, which led to being able to hire folks like Andy Wilson in his role full-time, but also invest in having the infrastructure that allows us to purchase equipment and to make investments like we are with this design phase, which again is not the normal work of public health, but really adheres to this principle that if public health is doing its job, our community partners and the community we serve is strengthened. So thank you.
Any other questions or comments?
No,
Oh,
thank you. Appreciate it.
You're welcome. Next is our Chief Operating Officer.
Okay, we have two positions that we're advertising for. We have a lot of staff that are going to be gone or are gone long-term for different various reasons. So we are hiring a temporary public health technician to help fill that gap, at least for the next 4 months and maybe longer depending on our staffing. And then we also have a policy and compliance coordinator that will start advertising for later this week. And then the other item that I want to report on, we have some sad news, but some exciting news. We're going to be losing our long-term attorney in January. So we do have 7 months to continue to work with him, but also we will be working with James Elliott on finding his replacement for the next 7 months.
That's the other part of your job, not James.
That's right. That's right.
Not everyone has that privilege.
That's right.
Yep.
Thankful for it.
I just wanted to express my personal congratulations to you. Happy for your moving forward.
Thank you.
You're welcome.
Congratulations.
Yes. If I could add, it's James has been a rock for us. He's been part of our team for many years and committed to our work in ways that we're really indebted to him for. So thank you.
Any other comments? Mr. Imach, anything else?
That's all I have.
Okay, great. We will move to local emergency response coordinator, Andy Wilson.
All right, thank you. On May 1st, YHD activated their INT for the H5N1 bird flu. We're working in coordination with WSDA, Washington Animal Disease Diagnostic Laboratory, and WSDA Extension and local partners. The goal is to develop a plan in the event that H5N1 is, we get a test positive in cattle in Yakima County. So trying to develop the plan so we can test and monitor potentially exposed individuals and provide support for the farmers and their employees.
Thank you.
Thank you.
Any questions for Andy this morning? Anything else, Andy?
Nope.
Okay, thank you. So we'll move to our financial report with Chase Porter.
Hi, good morning. The report starts on page 9 on the Board of Health packet, up on the screen. For the month of April, we had a $249,000 gains, bringing our annual excess to $681,000. Our allocated budget through the month of April was $3.9 million in revenue, and our total actual revenue is coming in at 4.1. For expenditures, our allocated budget was 4.2, and then our actual expenditures through the month of April was $3.4 million. Any questions on the summary? All right, moving into the next page. Looking at our income statement, again, we're still in our enhancing capital expenditures. Budget continues to grow. We're expecting to see those type of expenditures to start to happen later on in the year as we starting on the office remodel. We got a major uptick in operating supplies for the month. And that was due to the purchase of the medicine lock boxes that we will be giving out at some events. And then also our payroll expenses, we've been, as Ryan was just talking about, we can short 2 FTEs all year long. And so that's contributing to the deficit in the payroll expenditures. Any questions regarding the first page of the income statement? Yeah. Seeing none, moving into the second page. So there's not a lot to note in the last half of this report. Is there any questions? All right, moving into program studies. And program reports. Again, we're really dominant in FPHS. We've actually created a new program, FPHS epidemiology, and that had to do with the H5N1 disease that is going on right now. Also, we had for a big gain in our MAC billing again on 295 down in the Clay. We are going to see MAC billing to be a funding source throughout this year. We're trying to catch up on that. That fell into arrears during COVID. And the plan is to try to catch up in that this year. So there'll be additional MAC revenue throughout the year. Any questions? All right. Last page of the programs. EH is really busy. And you can see that with a lot of ups and downs within EH. We expect a lot of those to start to even out as the year progresses. Any questions? All right, last page of the financial report, cash flow. For the month of April, we saw a slight downtick in cash balance, as we would expect this time of year. I expect it to have a slight decrease next month as well. We would have an uptick come June, July. Any questions? All right, thank you. Back to my report.
Thank you, Mr. Hurd. Next, we will go to our health officer, Dr. Neil Vargas.
Good morning. Morning. I've had a couple of topics to talk about, but I wanted to, before that, just comment on great job being done in SBI by the nurses. When the congenital syphilis cases went up, there was a bunch of meetings with a large group of people, including OBGYN and intensive care at Memorial. And this went on during the outbreak, and it ended up increasing the amount of testing being done and then test and treat. So the ERs were talked to, some primary care providers. So if somebody came in and there was risk for syphilis, they would draw a test, but treat them right then and there. And that probably had an influence on what's happened with congenital syphilis, is basically dropped down to 0, which is where it should be. And that's all work of these guys. Also, the overdoses across the country are starting to decrease, probably as a result of increased availability of Narcan. The fentanyl problem hasn't gone away, but I think the Narcan's making a difference. Unfortunately, it's not yet decreased in Washington, but hopefully it will. The last thing I want to give a shout out to is our TB team. There was a case of a patient who came into the emergency rooms at various occasions because he was feeling more and more ill. It was kind of non-specific. And the patient was admitted to Toppenish Hospital because he felt so bad. And one of the hospitalist providers was worried about a TB test that was positive on the guy and previously was not. And he sent some x-rays up to us. We reviewed it, and it looked like he had miliary TB, which is one of the worst kinds of TB you can get. And we couldn't get anything done here in town. He needed a test where they looked down into the lung with a flexible scope called bronchoscopy. And he got transferred up to Seattle, and the diagnosis was confirmed there. They started treatment there, and he's come back here feeling better. He's actually able to walk in and out of the clinic. He couldn't get out of bed when he's in Toppenish. So the system worked really well there. And Tanya, who's the main TB nurse, made a lot of that happen, facilitator. All right, so I'm going to move on. COVID's still here. Big new strains keep cropping up. Hospitalization rates are staying stable or going down. For those over the age of 65, they recommend another booster. The booster is the same one that was available in the fall. And the new strains are still being covered by that fall booster. So as we get outside, we don't really know what's going to happen with COVID, but generally it's going to go down because people are outside more, not inside. H5N1, it's still around. There's a second case reported in Michigan. Michigan is one of the states that has herds that are infected, mild disease, and still, from what my research, there's been no human-to-human transmission among the contacts with the person in Texas or the contacts person in Michigan. In addition to milk, they've found virus in the meat, but still there's no indication that it can spread from meat to humans, especially if the meat's cooked. So if you're eating undercooked meat, that could be a problem, just like drinking raw milk is a problem because the virus is in there. And viable I'm not sure whether the meat was tested by PCR or whether they tried to culture virus from it. I had trouble finding that out. It might have been by PCR, which doesn't mean it's infectious. Next thing I want to talk about and provide a little fill-in on measles. In 2000, there were no cases of measles and it was considered eliminated. And since then, there's been 10 outbreaks. The one in 2024 that we've been talking about over the last few meetings, there was 142 confirmed cases, and 70% of those cases were associated with outbreaks, a cluster of cases. And measles has been reported in Arizona, California, Florida, Georgia, Illinois, Indiana, Louisiana, Maryland, Michigan, Minnesota, Missouri, New Jersey, New York, Washington, West Virginia, and Wisconsin. So this is not a focal thing at all. In 2023, there were only 4 outbreaks and 50% of the cases were outbreak associated. In the patients who became infected, as far as they can tell, they're either unknown, they couldn't tell if they were vaccinated or not, or unvaccinated. There's still cases that can occur in vaccinated people. It's quite unusual. With 1 dose of vaccine, the normal would be 2 doses. About 13% of the cases occurred in 2 doses of vaccine. There were 5% of cases. And what happens is there's a vaccine chain. So from the manufacturer, it gets refrigerated, it goes distributed, and then it's given to patients. If there's any break in the refrigeration, truck breaks down, it's delivered, but sitting outside and it warms up, the vaccine is not as effective or it's completely ineffective. So, and that's a problem that's not related to public health, except for the fact that public health can ensure that these deliveries occur. This is more a problem in developing countries than it is in the US. Interestingly, if somebody would walk into the room here with measles, they didn't know it yet, and they left for 2 hours, the virus remains suspended in the air and is potentially infectious. So it's just better not to have measles. The number of cases, fortunately, is decreasing overall. And if you look at vaccination rates, Washington is 90 to 95%. So that's the second best category. So we good vaccination program. Our neighbor, Idaho, less than 90% of the patients are vaccinated. And California, another neighbor, not direct though, which is okay, 95% plus are vaccinated. So that all has to do with health districts and county health programs and Department of Health programs. So when they work, they are very effective. I just want to make one other comment regarding, I forgot to say this, about how well things are working. The project that was discussed about UW looking at resources, I was one of the people interviewed, and I spent an hour and I answered a lot of questions and they went, really? So hopefully when we get the results back, there'll be some resources to expand and improve our programs for sexually transmitted illness. Next topic I want to talk about is a failure of the system, not due to the system not working, but due to bad practices by specific individuals. There were 4 new HIV infections associated with, and I don't know why they call this, vampire facials at an unlicensed spa in New Mexico. 4 patients were discovered that had contracted HIV by the primary care physician. And there was no risks involved in it's not sexually high risk. They weren't injection drug users. And they mentioned it to the Department of Health in the state. And they went and found out that all of these patients had attended this clinic that injected platelet-rich plasma, or PRP, into the skin of these folks for cosmetic reasons. The spa was closed down, and investigation was taken by the health department, and they found that there were a lot of infection control practices that weren't that follow well. So when this is done, the patient's blood is harvested and put in a centrifuge. And there is a section of blood, it spins out, there's layers. One of those layers has a lot of platelets in it. They withdraw those layers from the tube and they inject it into various sites, depending on what they're trying to do. One of the sites is knees, and it's being used by orthopedic surgeons for the past couple of years. It's very expensive, probably not covered by insurance. And according to the literature, there is no particular benefit to having those injections done. The people who get the injections don't do any better than people that don't get the injections for the same kind of knee problems, usually osteoarthritis. So getting back to the breakout in the unlicensed spa, they found kitchen counters with unlabeled blood tubes. They found a refrigerator with unlabeled blood, as well as Botox and lidocaine. And there was food in that same refrigerator. They had unwrapped syringes that were found in drawers, counters, and syringes were discarded into trash cans that were not labeled as biohazard. They're just regular trash cans. There was no means of sterilization on the premises, so there's no autoclave. So if they reused anything, it probably wasn't safely cleaned. And some of us remember back in the 80s, there was a dentist that had his technicians clean his teeth with the instruments in the office, and the instruments weren't properly processed. And one of the people, several people got HIV, but one of the people became very famous, Kimberly Bergalis, and it changed a lot of practices of surgeons, including dentists. She happened to be from the, was she in Tennessee? Do you remember that? She was a Tennessee person, yeah. Yeah, and Bill Schaffner got involved with that.
Dr. Barg, may I ask a clarifying question?
Sure.
When you were talking about they extract the blood, is it their own blood, the patient's own blood, and then?
Yes.
Okay, thank you.
Patients own blood. So, but there is, because there's needles that, and other devices used to inject it that weren't properly sterilized. If some person walked in there and happened to have HIV, their blood was contaminating the blood of the patients who then had injections with dirty needles, et cetera. So, blood got confused, so somebody's blood that had HIV unknown to those people was mixed with somebody's blood that didn't have HIV and they injected it. You're getting other people's platelets, not your own platelets back because it wasn't labeled. People couldn't tell. So that is a good reason why these places should be licensed. And it's recommended that a qualified physician or advanced practice person be in charge of this process. And the more of this stuff that happens in freestanding clinics, the more likely it's to happen because they don't get inspected at the same intensity at hospitals and hospital-associated clinics. So in addition to the sterilization process, that wasn't there, and the handling of disposable products, that means they were reusing disposable products. No patient information was saved. So they couldn't go back. It was really hard for them to identify the patients that had been through the clinic, and nobody knew whose blood, who's got what, whose blood. It was crazy. The other uses besides cosmetic and ortho, the dermatologists use it to augment wound healing, and the cosmetic is crazy. It's injections to decrease wrinkle. You have wrinkles, live with them. The last thing I want to talk about today is something that the health district talks about every summer, is extreme heat exposure. And there's no indication that we're going to have a cooler summer. Today is going to be surprising. I mean, in July, we're not going to have days like this. So Miami, Mexico, and India have already reported dangerously high temperatures. And what happens when you're exposed to heat? You get heat-related diseases. They can be mild, and the symptom might be a heat rash, hand swelling, cramps, and sometimes fainting, which we refer to as syncope. If it progresses, it will go to heat exhaustion, so it's all those symptoms, plus headache, nausea, vomiting, dizziness. And heat stroke, which is the worst and also fortunately least common, temperatures are recorded at 104 or above. And a couple of summers ago, there was a young woman admitted to our local hospital who on admission had a temperature of 107. And most of the people taking care of her thought she was infected and had bacteria in her bloodstream. So they got infectious disease involved, and we couldn't find any evidence of that. And we then, through talking to some family members, found out that she was in a room without air conditioning during that 115-degree stretch we had a couple summers ago, and it was from heat exposure. So she had heat stroke, multi-organ failure, and eventually passed away due to overexposure to extreme heat. And that particular problem, the heat stroke, is an absolute emergency. The patient has to be cooled down and hydrated literally within minutes of being discovered. So for any kind of heat-related symptoms, cooling and hydration are really important. And one of the places, like if you don't have air conditioning in your house, one of the places you should go is to the mall for the remaining time that it's open. I'm not sure, it doesn't look too lively these days. But getting into an air-conditioned area is really, really important. And without air conditioning, there's ways to do it. Just get into some cold water. And the more you're submerged, the faster you cool. Also, once you're out of the water, turn the fan on because the water evaporates and will cool you down. The youngest and the oldest are at increased risk. And it's even worse if you're on blood pressure medicines because the circulatory system doesn't work normally, since the things that make you have hypertension also prevent good cooling of the body. So the tip, avoid prolonged exposure. Gets really hot, stay indoors. Don't do stuff outside at 3 o'clock. You know, get all your work done at 6 a.m. And that's all I have today.
Thank you, Dr. Barr. Dr. Barr? Thank you. If not, we'll move on into disease control. Melissa Tipton.
Okay, so I'll start with our harm reduction numbers, just for totals for the year so far. Between the two sites, we've seen 564 individual unique clients with over 1,100 encounters and over 1,400 Narcan distributed between Toppenish and Yakima. We've had 302 encounters with comprehensive, 41 scheduled, and there's still the one admitted. So we're continuing though to meet them every week and trying to get them into services. The tribe has been very successful down in Toppenish with getting people into services, especially having the ARNP or Advanced Registered Nurse Practitioner on site who is able to get these individuals set up with medication assisted treatment right there on the spot in Toppenish. So that's been very successful down there. As Dr. Bark said, we do have the one new TB case that we're case managing. And then we were able to distribute, they're in the process of being delivered, 225 trigger locks to Yakima Neighborhood Health Services to be able to distribute at well child checks for individuals that have firearms in their home. And that's for 1 quarter, and we'll continue to do that. And then earlier this year, Chelan Douglas County had an outbreak of pertussis. There's been pertussis is also known as whooping cough. There's been a 6-fold increase in the state of Washington pertussis this year. So we actually have 2 lab confirmed cases now over the last week of pertussis in Yakima County with 2 epi-linked, meaning 2 of them were exposed to the individual and have symptoms. And so we've been working with the schools and providers, sending out a provider alert, getting individuals treated. It's a bacterial infection that's treated with antibiotics, but it can be you have to monitor for symptoms up to 25 days. So it's one of those long ones that you may not have symptoms, you could be spreading it and not know it. So it's one that we're really trying to jump on and get a hold of. And then I don't know if you have anything else you want to add to the pertussis.
One interesting thing in Chinese, the literal translation is 90-day cough. And it's in adults, it's not dangerous. It's just super annoying, but kids can die from it because it closes up their airway. And so it's a big deal when a really little kid comes into the emergency room and he has symptoms.
We can get people treated quickly when they're first symptomatic, then it decreases that time that they're having that cough. But yeah, it's the 90-day cough where you're coughing for 3 months, so pretty severe. The last time we had an outbreak, I think, was in 2017, 2018. I worked on that one, and it was all up and down the valley, and it was close to 100 cases on that one. So, and that's all for me, unless there's questions.
Any questions for Melissa this morning? Thank you,
Melissa, is the question, or the increase in cases or outbreaks associated with a decline in vaccination rates amongst pediatric patients?
I would assume so, but I also have known many of the people who are getting infected with pertussis seem to be vaccinated. It's one of those that just doesn't have the efficacy of, say, like the measles vaccine is. It's a really good vaccine. I don't know if you have anything, like your.
Yeah, the pertussis vaccines caused a lot of controversy in the past. That some other diseases were blamed on the vaccine. There's never been any good randomized studies showing that to be the case. In fact, a friend of mine published a study in Annals of Internal Medicine showing lack of correlation between central nervous system diseases in people who received the pertussis vaccine. She actually had death threats. And this is back in the 80s. So they called her up. So that was Vanderbilt paper. You remember that one? It's been constantly upgraded. Yeah. Yeah. But there wasn't, even back then, there was no link between the neurologic diseases that were linked.
Any other questions for Melissa?
I want to go back to Dr. Bard. Can you repeat why the lady got death threats again? Walk me through that, please.
Well, because her statements or her research showed that there was no link between the seizures and the reception of the vaccine. So in other words, they studied kids who got the vaccine. They studied another group, equivalent risks and stuff, who didn't get the vaccine, and there was no difference in the occurrence of these neurologic complications. So the vaccine wasn't contributing, it was just other things.
Thanks.
Any further questions? All right, thank you, Melissa. Thank you again, Dr. Bird. We will move on to environmental health, LaShawn McGee.
All right, good morning. There's a lot going on in environmental health. Currently, we're working on our PFAS sampling project. We partnered with the Army to conduct some split sampling and follow their quality assurance plan on PFAS sampling in the East Sela area, more to the west and the north, kind of the Pomona area up to the entrance of the Yakima River Canyon. It's an area that the Army was interested in, but through funding through the state, we were able to kind of expedite that effort. So we're currently collecting results on that and analyzing data from that effort, and folks who meet the Army's action level for PFAS will enter into their program for bottled water delivery until they can get a whole house treatment system. Folks that don't meet their action level at this time will get a point of use filtration system until action levels change, you know, the EPA and stuff like that, and the Army officially adopts those as well. So it's been a successful program. The results that I have seen so far, pretty low levels of PFAS so far, but I haven't gotten all the results yet. So once I have all that, probably definitely by next board meeting, I'll be able to kind of go over some of the data and show what that looks like. Some of the benefits of this too is that you know, we'll get the study, the plume of PFAS, which way it's traveling, how widespread it is in the area. And we're also looking at some feasibility studies around maybe more large scale water systems in the area, or that could provide relief and clean drinking water to households who are on individual wells that have high PFAS levels. What does that system look like? How large scale would it need to be? So one of the goals of this is to help support that feasibility and identify what our options are in the future. what resources could be brought to the table.
I'd like to ask a couple of questions if I could. So when you talk about the plume, is the full area of concentration north of, I mean, in the North Valley there, the Sela Firing Center area, or is that expanded?
I think a large portion of it that's been identified so far is south of the firing center exit there. I mean, there's a little bit to the north, but mostly south down to the Sela Gap and east of the river. So that kind of that medium-sized area south of the exit, firing center exit to the Sela Gap. And primarily the testing has been done east of the river. Some of our testing that we're doing now will get closer to the river to the north, and there's some even on the west side of the river. There down Harrison Road, so.
You haven't seen any evidence of it there yet, but you're gonna test.
Everything's been below the 4 part per trillion federal limit, and many of which have been non-detects, so. Nothing actionable at this, from what I've seen.
All right. Part of the reason I'm asking is that I was contacted, this has been a few months back, but there was a lady, I think in the Terrace Heights area, that had been concerned about PFAS. So it says, south of that ridge, and had her water tested, and I think they came in at 5 or something like that. So it was below the 4 parts per trillion. But I guess a couple questions with that. Do you think that's tied into the firing center PFAS, or could it be another source? And then the second half is, okay, if she's at 2.5, is there anything for her to do or anything to be really worried about?
So the latter part of the second question is, at this point, being below the federal limit, there's no actionable threshold that's been met by those samples. So that water is deemed drinkable at this point. PFAS is still new. Who knows what research in the future will find, but at this point in time, that's below any actionable limit. But it is telling that there's PFAS detection in the Terrace Heights area. Is it another source or from the Army? We don't know yet. We've discussed that with the Army and engaged kind of where they're at with sampling in the area. If samples came back with the same analytes of PFAS, PFOA as the plume coming from the firing center has, then they definitely would be interested. If there are different analytes, that would suggest it's a different source. So it's something we have to get looked at. And we'll be encouraging that moving forward.
Okay, so if this person wanted to have that looked at, who would they contact?
Well, the
To see if
sample
there's
they
still-
got, PFAS is the broad overall, category, and then below that, there's dozens of different chemicals that qualify as PFAS. So the sample should have a breakdown of what that was. If we can get our hands on that piece of paper, then, that would be telling.
Okay.
And I think I still have the contact information from those folks, so.
All right, thank you.
So that project will continue through the month of June, and we'll have all the results compiled and organized, and I'll have an update on that the next meeting. For our Guama's Safe Drinking Water Initiative, we've partnered with Yakima County on. Sampling still continues. There is more and more people joining the program every day, requesting laboratory samples and a site visit. So much so that our staff are able to do 15 to 20 site visits a week. And that's not quite keeping up with the big push to get as many folks done before the first part of this grant runs out June 30th. So we've looked at having our lab that we're working with also has a field component to their company. They're certified to do well site assessments and to go out and collect samples. So we're looking at getting them involved to make site visits on our behalf, and we're working with the county on getting that set up. I believe that's scheduled to be implemented next week if all the contracts get amended. So that's looking good. That'll allow us to get to a lot more folks more timely. Our staff will still compile all the septic records, all the well logs, and do the household demographic part of the site visit survey.
with these folks over the phone. Whereas, Valley Environmental will actually get eyes on the well, take pictures, do a write up an analysis of the state of the wellhead and collect samples. So, should increase efficiency of that project, by quite a bit. So we're excited about that. In the solid waste world, DTG has broken ground on the, installing the liner in the new cell area. I've seen pictures out there. It's just a big flat pad of dirt. It looks pretty impressive. There's a lot of earth moving going on. And they've started the process of drilling their new groundwater monitoring wells. So there's 5 new wells going in there. That work's scheduled to be completed sometime in August, I believe, is the last update they gave me. So real progress being made out at the DTG site. And we're still going through the process with PCHB in the Cape landfill. So not much to update on that one. Lastly, the last couple items were next week we have our West Nile virus surveillance kickoff. The second year in a row we're doing the mosquito trapping for West Nile virus surveillance. And that will be, a lot of that work will be done by the intern that we are bringing on from the University of Washington through their paid internship program. So we're going to have an intern helping us out this summer, which, you know, is exciting. We'll get to get a new person specifically in the environmental health program at UW, some real life experience, and we'll have another staff person to help out with some of our non-regulatory programs. That's all for me.
Question, Sean.
Yeah.
It was the Yakima Health District involved in all of the radiation exposure response in Sunnyside last week.
Environmental health. was-
Andy can answer that.
And
So we weren't directly involved with it. We got the report back with it, and I can provide a summary for it. But it was mainly State Patrol, Emergency Management, Yakima Hazmat Team helped out, and then they got DOH's Radiological Protection Team involved to go out there and investigate.
And what was the, it was construction, or what was the site, or what was the cause of their exposure?
So
Theoretically.
yeah, so in summary, some workers were working in Prosser, down in Benton County, in an enclosed area, cutting some pipes. They started to feel ill afterwards, and then, see, Friday, they took the pipes to a metal recycler. They've got a radiation detector on the metal recyclers. It activated. So they didn't accept the pipes. On Sunday, the workers still felt ill. They went to the hospital. They got checked out by the rad tech there and DOH's radiological team. And they went out to the site and checked the pipes. It was below background level. So they're thinking that the scale inside of it had natural radiation that set off the alarm at the recycler, but determined that there's no radiation exposure.
I just want to recognize that Edie Dibble has joined us via Zoom. Welcome, Edie. Thank you. Any other questions for Sean? All right, then we will move on. Next is our public health partnerships. Lillian is not here today, and Andre is going to report for her.
I won't do justice, but I'll make a good attempt. Thank you. So Lillian is the Director of Public Health Partnerships. I wanted to recognize that a lot of the projects that you've been hearing about are also partnerships that we have internally. We're working interdepartmentally on these projects. So when we talk about things like testing for PFAS, there's a communication aspect. And so there's a group of people who are working on that communication. When we talk about testing or monitoring of groundwater, we're basically also talking about communication to residents. So we want them to understand what's affecting their water. So it's not just testing the water, but it's an explanation component. And that's something that's been critical. So the team in partnerships is working very closely with and other groups. So this has been really helpful for us. I did want to share, we've had some really wonderful events lately. One of them was I think it was last Saturday, we had a safe firearm storage event at Coastal Farm and Ranch in Yakima. So that really was to ensure that people have access to trigger locks and lock boxes. That was a wonderful event. I think that the partners collectively handed out 198 lock boxes and 198 trigger locks. Yakima Police was on hand to do education. It was in partnership not only with Coastal Farm and Ranch, but a group called the Seattle Children's Alliance for Gun Responsibility, which provided the items for free. So those are not just training, one-on-one training, but those are free trigger locks and lock boxes, which we think is really critical to ensure the safety of firearms in the home. And also, we worked with the range, who was there to provide firearm-related classes and information. So really, it's a wonderful partnership. It's focused on gun safety, and certainly well received by the community, which we're really pleased with, and we'd like to continue. Any questions on that? Okay. We also participated in what's referred to as a Key Leader event on May 15th. And it really is about getting local agencies, community groups, and certainly local stakeholders, families together to learn about prevention being done by community coalitions and how to keep your home safe. So when you're talking about keeping your home safe, as parents, we always want our children to be safe, but sometimes you don't understand what some of those triggers are for people. What vaping utensils look like and what to look for in the home. So this was really a wonderful coalition group meeting to get people together. But again, it was open to the public, and so we were really excited. And really about prevention and supporting the work that's being done. And also educating about the use of naloxone. So we were pleased about that. Again, not our event, but we were supportive of it and a partner with it. And then finally, I believe Dr. Marissa Baker from the University of Washington is working to provide training to local organizations in juvenile court and Department of Children, Youth and Families on fentanyl awareness and safety training. So again, we're working on this idea of prevention. How do we prevent children and families from being exposed to fentanyl, to illegal substances, to accidental overdoses? Same concept when we're dealing with firearms. How do we prevent someone from having access to that? And I will also mention that years ago, there was data conducted research that indicated that Yakima County was a hotspot for firearm-related harm, self-harm, especially for young men. And so the idea when it comes to preventing that kind of trauma, that kind of attempted suicide, is to prevent the person from having the vehicle that would get them to that harm. It's, again, my understanding that sometimes people have these circumstances where they feel that they have no other options. If you can help prevent that circumstance or making it easier for them, then it actually can get them through that period. And then they find more balance. So we're really, really pleased about these projects. Again, for us, it's not just communicating to the public about these concerns, but it's also about building the partnerships that allow for more organizations to reach the people in our community. So again, in partnership, the health district is able to support work that's really pivotal to keep people safe.
I believe that one, excuse me, Andre, is specifically in partnership with ESG 105 and training people on the environmental effects of fentanyl. Not necessarily using them, but what it looks like if you have an exposure in a bathroom at the school, and training is on that.
Oh, and yes, that's actually critically important. One of the things that we found is that fentanyl is really often found in places in public areas, and so we see it in ways that we had not anticipated. So it really is something that's been important. And again, fentanyl test strips is something that we've supported through our harm reduction site, but fentanyl exposure is a concern for parents, and we've seen that repeated. So that's been something. Also, there are concerns in schools about public restrooms and the use of vaping and fentanyl and so forth. And that's something that's tragic and difficult for administrators. So that's something that we're trying to support, so they have all the resources available to them. Any questions on that? And that's all for me. Or Lillian.
Thank you. We're going to move ahead into unfinished business. And the first item is a health officer coverage discussion. Ryan Amok is going to lead us in that.
Okay, so the last several months, we've talked about how we're going to provide coverage for our health officer in case the absence of the health officer. Some of the things that have been talked about and discussed have been using a regional health officer that the State Department of Health has throughout the state. Another possibility has been using a local health officer in neighboring counties. Problem with both of those options, as Andre mentioned last month, was that several of those positions are, the people, health officers in those positions have either left or are relatively new. And so we also talked about a deputy health officer, but what we really need is a temporary, just a backup, not necessarily a deputy. And so the essential services that this person covered, the office of a health officer, including managing active TB cases, reviewing any TB labs, writing any orders that don't fall under standing orders, providing recommendations as needed, reviewing positive syphilis cases and staging the patient, and temporary signing off of standing orders that would also be needed. So it's not necessarily someone that would be doing policy or making decisions for the county, but more of these essential services in the absence. So what we would like to do is move forward with advertising for a backup health officer. This consists of probably several hours beginning on the training part of it, but then after that, there could be months where there's no hours at all. But then in the absence of the health officer, there would be some hours to provide these essential services. So we want to move forward with go ahead and advertising for that position, and then before next meeting, we would give the candidates any applications that we receive to the board, and then next month make a decision on how to move forward on that. So any questions on moving forward?
So this would be like a contracted position?
Yes.
Service as needed?
Yes. Mhm. Yeah, just an hourly.
Okay. Any other questions? Discussion? All
So
right,
move ahead.
yeah, thank you.
Thank you.
Next is new business, and we have none. So that brings us to adjournment. I would entertain a motion to adjourn.
I'll second.
Thank you. I didn't want to say. So we have a motion and a second to adjourn until our next scheduled board of health meeting on June 26th, 2022. All in favor, please say aye. Aye. Any opposed? You are adjourned. Thank you very much. Thank you.